Hello, hey, this is Dr. Scot Hutchison. Thank you for joining us for Hutchison's Huddle today, and from Tucson, Arizona, and we're going to talk about fertility evaluation. So this is a patient education deal because a lot of our patients really have a lot of questions about how the fertility evaluation should begin and how and when it should start. So first of all, infertility has become much more common over the last few decades. Now, we typically say, oh, well, people with polycystic ovary syndrome, for example, it's sort of like, one, or it used to be a very, very small percentage of the population. Now it's up to 15% of the population, and that's only really rising, I would say. Generally, the standard accepted time to begin an evaluation is if you have been trying to get pregnant, if the female partner is under age 35 for more than a year, or if the female partner is older than 35, then at about 6 months of attempts. And I would even say that in the later 30s that it would be even reasonable to go ahead and begin evaluation even before you try to get pregnant. Just because the timeline is so much shorter. So let's back up a little bit and talk about, even before you try to get pregnant, what you should be doing. So long before you are going to try to get pregnant, I think for a few months you should be trying to maximize your fertility. And by that, we want to make sure that you are as healthy as humanly possible, because and that's for a whole bunch of reasons, not just for your health during the pregnancy, but for the babies, and to minimize these imprinting or epigenetic modifications of the baby that can increase the risk of type 2 diabetes and obesity and things like that. So try to first think about having children as soon as you possibly can in your timeline for your life, as long as it's going to work out for you. So many people want to delay childbearing until they're a whole lot older. And I got to say, typically older parents are going to be better parents. They tend to be a little bit more mature. They tend to be able to kind of think, hey, I'm going to sacrifice my well-being for the well-being of my child a little bit more easily. But on the other hand, as we get older, both our eggs and sperm age so much that our fertility really decreases significantly. So I know that there are companies, a lot of these companies, the tech companies like Apple and Google and, they all are, Facebook, they're all paying for egg banking now. And I'm a little cynical about it. I mean, I'm glad that they're able to do it. But on the other hand, I think that there can be kind of a motive of, saying to the employee, hey, just delay having your kids here and just keep working for us, and you can get around to having those kids later. So I'm a little skeptical of that, because I think that in the big picture, about as soon as you realize that you really want to have children and that you feel like you can make that work, that probably is really the time that you should be trying to get pregnant. So having said that, I would say that about at least 6 months, maybe even more, ahead of trying to get pregnant, if you have the opportunity, that you try to clean everything up in your life as good as you can. So we want you to maximize your sleep to where you're getting at least, the average person who's in sort of reproductive age probably really needs about 8 hours of sleep a night. And, even for shorter periods of time, we really don't like to go under 6-7 hours. I think you've heard me talk about the University of Colorado study that was published this year that showed that college students that were sleep deprived, getting only 5 hours of sleep a night, over 5 days went from being totally normal to being all pre-diabetic. So I would encourage you to, get plenty of sleep, moderate exercise beforehand, so that you reduce the oxidative stress on the eggs, and that you eat really, really healthy food. And what we mean by that is what we call a Mediterranean type diet. I would also and it just sounds absolutely crazy, but I would eat kimchi or sauerkraut every single day, the active culture kind, starting about 6 months or more before conception, because this is really for maximizing your gut biome, which in turn will maximize your vaginal and uterine lining biome and make it make the bacterial content of all those structures as good as it can possibly be for achieving pregnancy and staying pregnant. And for male partners, I would encourage them to eat those fermented vegetables as well, because you are passing back and forth all that bacteria with your partner. So both eating very healthy food and eating those fermented vegetables. And then very importantly, take out alcohol, tobacco, recreational drugs like marijuana. Just because the marijuana is legal now in a lot of places, and it is around here, doesn't mean that you should do it when you're trying to get pregnant. So I would strongly encourage you not to use any substances. In particular, any things that are smoked or inhaled tend to ramp up the detoxification machinery of the liver, and that in turn tends to cause your metabolism of your hormones like estrogen and testosterone to be, a little more vigorous, and they tend to be, and so you'll lower those hormone levels with smoking, vaping, and all that kind of stuff. So I would strongly encourage you to get rid of that, get all that out of the picture for many months before you actually try to get pregnant. At least, with alcohol, I think the data is at least 2 months, but I would encourage you to go even further than that, because it may be actually beneficial to discontinue with those toxins well ahead of that time. Likewise, starting about 3 to 6 months before getting pregnant, we like you to start taking prenatal vitamins. So you don't have to take extra folic acid, I don't think, as long as you're taking that prenatal long before you get long before you start getting pregnant. It takes about 3 months for the folic acid levels in your blood to build to the place where you are most protected against having birth defects of the brain and spinal cord for the baby. So then the fertility evaluation typically is a semen analysis for the man. And at this point, we really are at about a 50-50 point, at least in our practice, where we see about 50% of the causes of not getting pregnant is due to male factor, then about 50% from female. But there's a whole lot of overlap in there, and we see couples where they both have problems. So you check a semen analysis. The best way to get your best semen analysis is actually to ejaculate for 3 days or more every day before the analysis, and then take a couple of days off. And then if you can collect the sample at home where it's a little more private and arousal can be a little bit better, then we encourage you to do that. And we like you to kind of take your time collecting the sample, because that arousal really influences the amount of volume that you get, and really may get us a better fraction of sperm production as well. So that's the semen analysis. Then we typically like it to the office within an hour or so, and you can just keep the sample at room temperature. If it's really hot or really cold, be careful with that. Certainly, sperm need to live at about 3 degrees Fahrenheit cooler than the core temperature, so we don't like them getting really hot. Then on the female side of things, the evaluation usually is a detailed history. So like, how are your menstrual cycles? What medications do you take? What other medical problems do you have? Family history of infertility problems in particular. And then there's as time has gone on, as you all are probably aware, there's more and more genetic research being done. And nowadays, if you have a family history, even an aunt or an uncle or a great aunt, great uncle, who has had one of the 5 sort of genetic cancers, so before age 50, and those are breast, uterine lining or endometrial, ovarian, prostate, and colon. Those, if you have a relative with one of those 5 cancers, it's before age 50, you should be offered genetic marker screening to see what your risk for developing those tumors is. So that history is really important. We also like to know if people have allergies to medications and things like latex. The crazy thing is that a lot of us still like to use latex ultrasound transducer covers because they give us a little bit better image quality. But boy, if you're latex allergic, that can be a disaster. So if you have a latex allergy, please, when you check in at the front desk, tell them. And then anytime somebody says, "Hey, come with me back to the back office here to where the exam rooms are," you always remind them, "Hey, I'm latex allergic." And don't feel like you're being overly cautious about that, because we really don't want to have somebody have anaphylactic shock because of the latex exposure. Then the examination part of a first visit is typically examining or doing vital signs, so weight, height, blood pressure, and then we like to check the thyroid gland. Breast exams are kind of, unless people are having breast discharge or bleeding from the breast, we don't really care about them so much anymore, because breast exams really are a poor way to find tumors in particular, and most people have had one within the last year for their annual exam anyway. But if you have a mass, or you have a mass in the axilla underneath the arm, be sure to tell the doctor, and they'll examine that for you. And then you examine the abdomen. We do a quick pelvic exam. Everybody should be screened for gonorrhea and chlamydia every year while they're trying to get pregnant. So we typically do that. You do a bimanual exam, so the doctor puts fingers in the vagina and then pushes from above to feel for things like endometriosis or fibroids. And then we do a transvaginal ultrasound. And what we're looking at as far as the ultrasound, we want to make sure that the uterine cavity configuration looks okay. We want to see if there are any uterine fibroids, if the uterine lining looks like it's being displaced by some other mass, or if it has cystic structures within it that could represent something bad. And then we like to look at the ovaries and make sure the ovaries look normal in appearance. And normal ovaries are about the size of a walnut, and they have a few follicles. Usually under age 35, you're looking at probably 8 to 10 follicles, all different sizes. And, like lots of times you'll see a pre-ovulatory follicle, or one where, the patient's ovulated over the last, week or two. And then after that exam, we like to come back into the exam room, or into the consultation room, and you talk about checking the fallopian tubes. And that test is called a hysterosalpingogram, or HSG. And that test you usually do after a menstrual period, but before ovulation. And the reason that it's timed that way is that, unlike ultrasound, which is just sound waves, the HSG uses radiation. It uses a small amount of ionizing radiation. So that's called fluoroscopy. So it's real-time X-ray. And we like to do that before you might ovulate, because if you got pregnant right at that time, we wouldn't want to radiate an early embryo. Eggs and sperm, their DNA is wrapped up pretty tightly, and it's fairly resistant to the effects of radiation. But early embryo DNA is being accessed, so it's being peeled off those structures called histones that the DNA is stored on, and it's being used, it's being transcribed, and so it's very vulnerable to hits from radiation. So we like to hold off on that HSG test to either that early part of the cycle before ovulation. Then the next step that we usually do is have blood drawn somewhere early in the menstrual cycle, like usually day 2 to 3. And those laboratory tests will help us determine egg reserve and other just general health conditions. So to determine egg reserve, we usually check what's called anti-Mullerian hormone, or AMH. That's a protein that is made by the cells that surround the eggs. And that protein is then released into your blood, and we can pick it up in the serum. And typically, you want to see a fair amount of that in the blood. Women who make a lot of, just a ton of it, usually that's a sign of altered follicle recruitment. So women with polycystic ovary syndrome typically have much higher AMH levels. We also look at the follicle stimulating hormone and luteinizing hormone levels. And typically what we're looking for are follicle stimulating hormone levels under 10 milli international units per milliliter, and usually the luteinizing hormone level early in the menstrual cycle is a little lower than the follicle stimulating hormone level. And that's mainly because at that point in the cycle, those hormones are being made at about the same amount, but the luteinizing hormone is cleared from the kidney a lot quicker. So it tends to be a little bit lower. If we see that ratio reversed and you see that the luteinizing hormone level is a lot higher than the follicle stimulating hormone level, then that's a sign of altered ovulation. So things like polycystic ovary syndrome. But we also look at thyroid. So we look at a thyroid stimulating hormone. We look at a prolactin level because prolactin, which is a hormone for nursing, can, if you make too much of that, it can alter how you ovulate and stop you from ovulating. We also check German measles titers and chickenpox titers, so rubella and varicella. And a lot of people, I would say about 5 to 10% need revaccination on one of those. And those are important because if you get German measles during the second or third trimester, or rubella, that's associated with about 50% of the children having neurosensory deafness or other problems with the brain. So that's really important. For the chickenpox, it's really important to be immune to that heading into pregnancy, because if you happen to get chickenpox when you're pregnant, you can get a horrible lung inflammation that can be fatal. So definitely you want to make sure that you're tested for those before you get pregnant. And a lot of this testing you can do, months before trying to get pregnant as well, so that you get ahead of it. And if you needed to be revaccinated, you could. Both the chickenpox and the rubella are what are called live attenuated vaccines. So typically we tell people, hey, don't take them, right when you're trying to get pregnant. But on the other hand, I've never had anybody have a problem, and I've had people who have accidentally gotten pregnant after being revaccinated and have been just fine. And I think that's more of a theoretic risk than anything else. We also like to check the serum sexually transmitted infection labs. So HIV, hepatitis B, hepatitis C, and syphilis. Those are useful to do. And we like to check just basic, like a chemistry panel and a complete blood count to make sure that people are, that they don't have any other underlying anemia or, like their cholesterol super high. And that does, incidentally, looking at a lipid panel on a patient can sometimes be very insightful as to how their nutrition is. So lots of times you'll see that like the triglyceride levels are really high, the good cholesterol levels are really low, bad cholesterol levels high. And you know that for this person's general health, not just for getting pregnant, they really need to tighten up their diet a little bit or a lot. Also, we like to do a red cell antibody screen before you get pregnant to make sure you're not making antibodies against red blood cells that could affect the baby. And diabetes screening is a good idea too. So typically we'll do a hemoglobin A1C for patients. And then for patients with irregular periods or who we think have polycystic ovary syndrome, we typically draw a progesterone level and a 17-hydroxyprogesterone level to screen those people for an adrenal enzyme problem that can look like polycystic ovary syndrome, but it has nothing to do with it. And that would be treated a completely different way if they did. And we typically check a testosterone level. And then if they have abnormal hair growth, we also check a DHEA or dehydroepisterol sulfate, so DHEA. And there's no real need to draw androstenedione levels anymore. But anyways, that's basically the blood work part of things. And then typically we'll be able to figure out where people are going with that. People who are ovulatory, we tend to then, talk to them more about then going on to fertility treatment, like letrozole with intrauterine insemination, or clomiphene with intrauterine insemination, or moving on to in vitro fertilization, depending on what the deal is. Certainly if there's all kinds of tubal problems or it seems like they've got bad endometriosis, then we tend to start talking about more aggressive fertility treatments sooner in the picture. For people who are just not having ovulatory, or we're not ovulating, we just go ahead and get them ovulating. Anyway, so I have a question from somebody. Before doing an IUI, do you make sure sperm is good to have a successful IUI? So that's an interesting question. So clearly, the health of the male partner makes a gigantic difference with regard to how the sperm are going to work. So just because a guy has good sperm counts and motility doesn't mean that those sperm are going to be quite as functional as far as yielding really high quality embryos, especially if the guy is using substances or is drinking alcohol. We know that the male alcohol use, for example, even one beverage a week will lower the chance of pregnancy by about 20% per cycle. So we think it's really important for the male partner to have really good health habits and be functioning really well before they do fertility treatment, if humanly possible. I mean, if you can't get any traction with getting them any better, that's fine. Certainly guys who have lower sperm counts and motility, we try to do everything we can to try to maximize that. So for males, we really say there's kind of a laundry list of things that we like males to kind of look at. First is, stay out of hot tubs and saunas or hot baths. You don't want to immerse the testis because it really will damage the sperm genetics. Sperm DNA fragmentation is much more accelerated if the sperm is exposed to higher heat. And again, sperm are supposed to be 3 degrees body temperature or 3 degrees cooler than body temperature. So instead of being 98.6, they really need to be around 95.6. I mean, they need to be, that's why the testes hang outside the body. We also tell people, avoid long road cycling, motorcycling. I like guys to have motorcycles if they're having problems with sperm counts or motility, just for that reason. Avoiding junk food. There was a randomized trial, the big one in Europe a couple of years ago, that showed that the guys who were given the junk food and encouraged to eat it had progressively, you could just watch their sperm counts go down over month to month. So staying away from junk food, making sure that Mediterranean diet with a lot of really healthy nutrition, lots of leafy greens, vegetables, fatty fish like salmon or sardines, daily, some kind of fish, most days of the week is a really good idea. Nuts as well, really good for male partners for improving sperm motility, and good fats like olive oil and butter. We used to say that carnitine compounds appeared to be helpful for male fertility, and I think that's a little more questionable now. And the carnitine compounds may actually increase the risk of heart attack, of coronary atherosclerosis. So I would stay away from them, and I would just eat really healthy food, get moderate exercise, plenty of sleep, and stay away from toxins on the male side as far as those IUI, if you're going to be doing an intrauterine insemination. So, and then I had another question: where in your cycle or treatment plan does the thorough blood test panel happen? So typically for women who are having regular menstrual periods, we like to do it on cycle day 2 or 3. Because that's when the hormone levels are really the lowest. And so it's really probably the most valid time for those patients, because the follicle stimulating hormone level, if you check it right around the day that you're also getting a luteinizing hormone surge, the follicle stimulating hormone level goes up a little bit too. So that can make it look like you don't have as many eggs when you're perfectly fine. Now, a lot of the time I'll have patients who have regular periods, but it's the middle of the cycle and you do the ultrasound and they're not ovulating at all. There's no big follicle there. So those patients, you can just go ahead and get the blood drawn the next day. And we like people to be fasting, especially if we're going to be screening them for diabetes. But we like them to be fasting, but drink about a pint of water or a liter of water about an hour or so before the blood draw, so they're not too dry. Because if you go in and you're dehydrated, it makes the blood draw harder, which is more stressful, and then it may elevate your prolactin level falsely, and also you're just kind of hemoconcentrated, so it can make things look a little bit more abnormal. So then there's a thing about a second opinion in here. A question about second opinions. Second opinions are always really good, especially if you have anything that's important pretty much in medicine, it's reasonable to get a second opinion with. And you should never feel bad about that. And I don't, I have patients who are like, I'd like my records and go get another opinion. And I think that's great. I can remember when I was having back problems and I had to have back surgery, you bet I had second opinions. And because it's really important. It's really important to know that the clinicians are kind of on the same page and that you don't have wildly disparate views of what's going on or what the diagnosis is. And then also, I think it's really important that you find a practitioner where you feel like that you really feel like that they're tailoring the treatment to you. I kind of feel like in fertility medicine, we have kind of protocolized things, and certainly for people with unexplained infertility, it really is just down to there's the letrozole and Clomid with intrauterine insemination and IVF. The in-between steps where we used to do injectable fertility drug, I don't use those except if I can't get somebody to ovulate with the pill form stuff, because a couple of randomized trials showed that they were of no benefit in terms of increasing the pregnancy rate, and they only cost more and they raise the risk of twins and triplets. So I really feel like things that on the unexplained infertility group of folks has been really protocolized. But one of the kind of strange things with fertility medicine is that even patients who just have polycystic ovary syndrome, or where the guy just has a little bit low sperm count, are being kind of shoved towards IVF. And I really feel that's a disservice to everybody. So because those patients are going to usually get pregnant with much easier stuff that's a lot less invasive for them and a lot less costly, and they're not going to be creating a whole bunch of embryos potentially that they may never use. So I think it's important that you kind of map out a plan with a clinician to where you feel like your individual case is really at the forefront of what's going on, and not just the good of the fertility clinic. But anyway, what else? And there was a question about how long should consultations be? Consultations are usually around an hour and a half. The way we do it, I usually get the history forms in advance. I usually look those over. I usually kind of create another whole encounter, because I like to see a little narrative that everybody can, the whole team can look at and say, hey, what's going on here with this patient? Why are we doing this? And so it's really nice to have a nice history of the present illness and all of that history. And then what I like to do is go ahead and flesh that out with the patient and me do the individual data entry, asking about their family history and, making sure that all that's super accurate, and then the exam, and then talking about what the plan should be. And I feel like those longer visits up front, they're burdensome for everybody, but in the big picture, if you get the first visit done well, and the clinician knows what's going on with the patient, and the patient feels like they have a rough understanding of what is going to happen as far as the evaluation, I think it makes it a lot easier down the road, and it's a lot less stressful for the patient. And certainly for us, when we're looking back on the record and we're trying to figure out, like, why are we doing this, we can really figure out pretty quickly, why. So anyway, and again, it's important for you as the patient to, if you don't understand why things are being done, that you ask us. So, feel free to call. I mean, everybody has different backgrounds with this, and like I have a lot of patients who are physicians, and nurses, and that's a joy, because they're usually ramped up and they're on the same page really fast. But on the other hand, a lot of people have no science background, and they have no idea what's going on. And so feel free to say, hey, look, can you drop this back for me a little bit and go over tell me more about why we're doing this, because it really is important for you to understand what the rationale is, so that there's not medication errors on it. So anyway, so that's the deal. Okay. Hang on a second here. On the day of consultations, will our husbands need to provide a sample for analysis? No, you typically do that. We can do that down the road. So that doesn't have to be. I can remember when my wife and I went in for the fertility thing, that totally blindsided me because I didn't know, and the doctor was like, "Here, let me take you back to this collection room," and then he handed me a Playboy magazine and a collection cup, and I was just kind of like grossed out by that. But anyway, you can no, we're not going to have the guy produce a sample typically on demand. Oh, and somebody says I have fat fingers. Sorry, I have fat fingers. I don't know they're really that fat. Are they fat? Somebody says, how do you account for the difference in grading scales between clinics? Hang on here. So I think that's referring to embryo grading scales. So and then they say is tested recommended on lower graded embryos. So embryo grading is usually there's all different kind of paradigms. Most people stick with kind of a 3-part one, and the first part is that the expansion of the blastocyst. So now that most of us are transferring only blastocysts, you're looking for how expanded that embryo is. Especially now that we're doing mostly just freeze all cycles, because fresh embryo transfers or embryos that you're transferring on the cycle where the eggs come out cause more preterm deliveries. Then when we wake those embryos up and warm them up, if they start re-expanding, that's a sign that the cellular pumps within the embryo have turned back on, and the embryo is actually is alive and is functioning well. So if you look at an embryo and you say, like, this is a 4AA, 4 means how expanded it is from 1, which is not expanded, to all the way to 6, which is where the embryo is hatching out. Then the first letter grade is the quality of the inner cell mass typically, and that's usually A through C, although sometimes you'll see 1 through 5, but it can also be 5 through 1, so you have to ask the clinic, like, what schema are you using? And then the second letter grade is about the quality of the outer cell mass, which is the trophectoderm. And that's going to be, so the inner cell mass is going to be the baby, the trophectoderm is going to be the placenta. So in our clinic, I mean, it's a little, and those are subjective evaluations. So in our clinic, because the pregnancy rates, when we call an embryo a C, so like if the inner cell mass is a C or the outer cell mass is a C, our embryologists are pretty critical of, and so if they call it a C, man, that's a bad embryo. That embryo is probably not worth biopsy, at least in our clinic, and it's not worth freezing, and it's not worth transferring. So if you have embryos that are lower grade, then what you really need to do is ask the clinic. You got to ask the clinician, hey, what do you and your embryologist see for pregnancy rates with these C grade embryos? So like we get embryos shipped in here that were created other places that are CC embryos, and when you thaw them, they just look like dirt. I mean, they don't even survive thaw. So, and we know that a lot of those embryos are not genetically normal. There are genetically normal CC embryos, but again, there's so many different things that can go wrong with an embryo, even beyond genetics, that if the embryo quality is super, super poor, then we usually don't recommend transfer of those embryos because they tend to yield more negative pregnancy tests and more miscarriages, at least in our experience. Anyway, so if anybody has any other questions about fertility evaluation stuff, ask right now, because I think that's about all for fertility evaluation. Oh, but I will say, we used to do laparoscopies on everybody. So laparoscopies where you do surgery, where you have general anesthesia, you put a telescope in through the umbilicus, make several other port sites in the abdomen and look around. And So that was standard stuff. So we did that on virtually every new patient back when I was a fellow and then early out into practice. And then there was a significant amount of data that came out that said, and what we were looking for was endometriosis or pelvic adhesive disease. So, people knew, endometriosis patients and these patients with pelvic adhesive disease tend to not get pregnant so easily. So we should do laparoscopies on all of them and look for that and get rid of it. And then a bunch of data came out saying it doesn't matter that much. I mean, if you've got endometriosis and you do an extensive endometriosis resection, you're only going to improve the chance of pregnancy maybe, 0.5% per month over about a 3-year span. So I think we reserve surgery like laparoscopies for patients with pain. So bad period cramps, pain with intercourse, like especially deep penetration pain with intercourse. Those are signs of like endometriosis nodules. And yeah, taking them out may not improve the chance of pregnancy very much, but it can sure make the pain less and the pain with intercourse a whole lot less. So, and if you think about it, now especially that we are trying to shorten abstinence periods and telling people to have intercourse every day because it's better than every other day, then if you have horrible pain with intercourse, that's just torture. So there's still a place for doing surgery, but that's really not really part of the fertility evaluation anymore. Anyway, and some other questions. How often would you recommend sperm testing? Yearly, or is once enough? I think that in cases where, like, let's say the woman is just not ovulatory and we're just trying to get her to ovulate, I think checking an initial semen analysis and then maybe another one about 6 months into it if she's not pregnant is probably a pretty good idea. Certainly if the guy's health status changes or if he has used some kind of supplement that's new, or a lot of our male partners have been kind of suckered in by this advertising. Are you tired? Do you have low T? Do you have trouble feeling like you're a man? Which I think is sort of this weird elliptical thing of trying to say, do you have erectile dysfunction? And, what guy doesn't feel tired or have erectile dysfunction sometimes? But they'll get suckered in and then they'll be put on supplemental testosterone injections, sometimes, every week. And then it'll just drive their own testosterone production down into the basement along with their sperm production. So certainly if a guy has any new medication, sometimes some of the antidepressive medicines or other medicines may seem to, or even narcotics. We really like guys off of narcotics because that seems to really pull things down. But in any of those cases, if there's new onset of medication, probably not a bad idea to check another semen analysis. But anyway, I think, most of the time, once a year is plenty good. On our patients who are doing fertility treatment, like intrauterine inseminations, basically you're getting a semen analysis every time you do an insemination. You're not getting the morphology, but that's a really subjective thing anyway. So anyway, if that's all the questions there are on fertility evaluation, then we'll stop. Please look back on our Facebook page for other Hutchison's Huddles, especially my ones with my collaborators, several really fine OBGYNs who are here in the Tucson community. Oh, and I'm getting more questions, sorry. What do you typically recommend when fibroids are present? Well, if fibroids are not in the uterine cavity or directly adjacent to the uterine cavity, they can probably just be watched. There are some kind of exceptions to that. If you have really heavy bleeding, and especially if the fibroids have grown and the bleeding has gotten heavier, even if the fibroid isn't near the uterine cavity and your doctor has done a full evaluation to rule out other causes of heavy bleeding like thyroid problems and uterine lining, infection, things like that, then those fibroids probably should go as well. But that's a little dicier. But certainly if fibroids are in the uterine cavity or are directly adjacent to the uterine cavity, they need to be removed. The sad thing is that removing them doesn't really it improves the chance of pregnancy, but it doesn't return you to kind of baseline. So also with uterine fibroids, there was a very elegant study from 2017, I want to say, for infertility and sterility, where these investigators cultured uterine fibroid cells in vitamin D sufficient and vitamin D deficient media. And the vitamin D deficient media cells grew much, much faster. So take your vitamin D. Most people are really vitamin D deficient. I would take at least 2,000. You don't want to take too much because it could give you kidney stones or it could potentially be toxic in other ways. But I think taking a prenatal and taking 2,000 of vitamin D3 a day is probably a really, really good combination. Also, before I forget, especially for the women who are over 35, but I think anybody who's planning on getting pregnant, I would probably start taking coenzyme Q10 about 6 months before I started to get pregnant. And the coenzyme Q10 needs to be in a legitimate form. In the United States, there's very little penalty for selling completely fraudulent supplements. So I would make sure that you get a legitimate form of CoQ10. And the brands that I typically recommend are the Cunol brand that Costco sells. That's 100 milligrams. That'd be 2 to 3 times a day. The Neo Q10, which is from Theralogics.com, and that's 125 milligrams every 2 times a day. And then the Gero brand, which is 100 milligrams, and that's 2 to 3 times a day as well. Those are all in medium chain triglycerides, and those brands are all subjected to independent verification so that they're not selling you something that's false. Somebody says, when you say intercourse every day, do you literally mean every day or every day during the fertile window? So it's really difficult to figure out when people are fertile. So I typically will tell people that a few days out, like if they're having regular 28-day cycles, I would say start about cycle day 9 or 10, and then every day through probably around day 18, 19 in there. And I know that can be a real chore, so I would encourage you to be nice to each other and try to be a little romantic. But it gets very difficult, I know. I've been there. But there is really good data. In 2017, there was in January of 2017 in fertility and sterility, there was a committee opinion on maximizing natural fertility or natural conception. And every day is better than every other day, but you do not have to stay down after intercourse. That was only found to increase the risk of urinary tract infection. And position during ejaculation does not matter. But act enthusiastic, try to be nice to each other. And then somebody says, if not 6 months on CoQ10, what is the minimum monthly? It's hard to know, but we try to, like with IVF, we try to say at least 2 months. Because it seems like that does a better job for us. That's, a couple months interval on the CoQ10, I've seen improve people's AMH levels. So like if I have somebody who, like I remember one patient had an AMH of like 0.6 and, with a couple of months of CoQ10, and granted there's some variation, but her AMH about doubled. So, or 1.3. So, I mean, I think it can make a significant difference in that. As far as DHEA supplements, so again, this is dehydroepiandrosterone. This is not, I don't think it's very good. We've tried it. The little nugget of truth is that DHEA is converted to testosterone in small amounts in the ovary, and in the ovary, testosterone has been shown to improve egg recruitment in small amounts. So, polycystic ovary syndrome patients are making buckets of testosterone, and it is not good for their eggs. So, but in low responders, supposedly testosterone supplementation, there is data that it is of benefit. We have used it in many protocols in patients, and we have seen relatively modest results with testosterone. DHEA, I've not seen really much, and I've had a lot of complaints of greasy skin, acne on the back, and just generally feeling, not very good. So I have backed off from giving people a recommendation to start DHEA. But the dose, if you want to do it, is 25 milligrams 2 to 3 times daily for poor responders, but I wouldn't give it for anybody else. So anyway, if that's all, then we will end our Facebook Live session, and thank you all for your attention, and I hope this was helpful out there, and you all have a beautiful evening, and have a great night. One thing more. So next Tuesday, we have a really cool Hutchison's Huddle. It's on third-party reproduction. So that's like using a gestational carrier to carry a pregnancy for people. And that's going to be with a really fine attorney named Heather Strickland, who does adoption law. And that's November 5th at 7 p.m. And you all have a great night. Thanks.